The question is, as moved by Dr. Tan Yaswam, Dr. Shahira Abdullah.
Before I begin, I would like to declare that I am an orthodontist working at Kutikport Hospital. Madam Deputy Speaker, we are now in DOSCON Green, the lowest health alert level since the COVID-19 pandemic began. The COVID-19 pandemic has had a profound impact on the world, with healthcare workers playing a vital role in providing critical care to those who need it. As we begin to move beyond the pandemic, it is clear that we need to continue to prioritize and support healthcare. This motion acknowledges the importance of healthcare in our society and seeks to ensure that healthcare workers and patients alike receive the support and resources they need to thrive. It recommends a whole-of-government approach to building a healthier and more resilient society for all. Beyond the pandemic and towards the future, I would like to touch on 3 areas that require our continued attention and support. Firstly, the manpower shortage of healthcare workers, which is related to burnout and the mental well-being of healthcare workers. Secondly, the provision of dental care to our migrant workers. And thirdly, supporting the special care and geriatric dentistry scene. Firstly, the manpower shortage of healthcare workers. Healthcare workers have always faced intense stress, emotional situations, and challenging working conditions, with long and unpredictable work hours, risk of injury, and exposure to diseases. These factors can contribute to burnout and mental health issues even before the pandemic. Although short-term measures such as counseling and mental health programs are crucial, it is imperative to address the underlying root causes of burnout and mental health issues. This requires addressing systemic issues such as workload, work-life balance, support, training, and the workplace culture. And at the core of this is actually manpower shortage, which MOH is already trying to address. However, even globally, there is a competition for a scarce healthcare workforce. Singapore experienced a significant attrition rate for foreign nurses, which increased from 9.5% to 14.5% between 2019 and 2022. In her COS speech this year, SPS Madam Rahayu mentioned that the loss of both local and foreign nurses to our competitive countries is a key reason for the stress and high workload for our nurses. We need to replace the manpower lost to other countries, safeguard the welfare of nurses, and meet increasing needs. If we were to go one step further, we need to ensure that our healthcare workers are supported and have the resources they need to provide the best care possible. We need to be fed or buffer into the system. I have a few suggestions on how we can retain and attract healthcare manpower. Number 1, granting permanent residency to the immediate family members of healthcare workers who are good performers. MOH is supportive of fellow NMP's Dr. Tan Yaswam's suggestion of granting PR status to foreign healthcare workers who are good performers. For these good performers, can we go one step further and automatically grant their immediate family, namely spouse and children, permanent residency as well? I know of several dental nurses at my workplace who have left due to this reason. After repeated applications, they have in the end given up, choosing instead to uproot their whole family to places such as Canada, New Zealand, and Australia. If we grant permanent residency to their family, they will sink their roots in Singapore, and the likelihood of losing them will reduce. When we lose good performers, especially senior ones, we don't just lose a worker, we lose their years of experience in our healthcare system. Number 2, ensuring remunerations are competitive locally and internationally. Singapore's public healthcare sector has increased the base salaries of nurses by 5% to 14% by 2022 with retention payments as well. I am aware that MOH monitors our pay competitiveness locally and internationally regularly. Salary may not be the sole determining factor for healthcare workers, but it is still an important consideration for many individuals when choosing their career paths, especially with the tremendous demands of care work. It can also incentivize foreign healthcare workers to continue working in Singapore. Honestly, higher pay packages will always help. Number 3, flexible work arrangements. This is something member Dr. Tan Wu Ming has also spoken about at length during the COS debates. And it is something I cannot overstate the importance of. Healthcare workers are also mothers, fathers, daughters, and sons. They may have an elderly parent or young children at home. Yes, there are already flexible work arrangements available for healthcare workers. However, MOH and MOM can work together to come up with more creative permutations of flexible and family-friendly HR work practices suited for healthcare workers in different stages of their lives, as well as the unique needs of each healthcare setting. For example, other than staggered shift times, we can consider having flexible shift lengths that split shifts into shorter scheduled times, or offering healthcare workers even more paid leave. Number 4, increasing the public's respect for healthcare workers. The public should understand that healthcare workers are not just transactional service providers who need to kowtow to the patient's demands. There should be zero tolerance for abuse or threats. Therefore, I'm encouraged by the great strides that we have taken in this area and with the recommendations of the tripartite work group to prevent abuse and harassment of healthcare workers. My fellow NMP, Mr. Raj Shashwat Thomas, will speak further on this topic. Number 5, improving the home caregiving landscape by providing broader support and help. To relieve the healthcare sector, caregivers are the foundation of aging in place. However, I've witnessed from my relatives how difficult the journey can be. One low-lying fruit that we could consider is having more caregiver-inclusive HR work practices and granting more elder care leave, a suggestion that has been raised before. Another is how we can work between ministries to ensure that families who are already overwhelmed can navigate the different caregiving options and available subsidies, ensuring that every family about to start this journey is attached to a medical social worker who can do a needs assessment and guide them along the way. This is so that while they look after the needs of the elderly, we should also do a needs assessment for the caregiver itself, so that they are not ignored, whether in self-care for their mental well-being or financial security when they themselves grow old. Secondly, let me turn my attention to the importance and provision of dental care to vulnerable cohorts, particularly the migrant workers, the geriatric, and the special needs population. Dental health is a very important health aspect that can be easily overlooked, but modern research has shown links between oral health, systemic health, and quality of life. For example, gum disease can increase the risk of diabetes and infective endocarditis and other vascular diseases. Dental pain due to neglect can also be debilitating. We cannot ignore the importance of oral health and its impact on overall health and quality of life. However, for the migrant workers, even if the dental treatment is deemed necessary, employers will have to bear the cost of dental treatment, and dental treatment can be costly. Currently, the primary care plan ensures accessible and affordable health care for eligible migrant workers. May I suggest extending this to dental care for migrant workers as well? The care may not need to encompass all dental care, like routine scaling and polishing, but really to address the urgent needs, which means pain cases, which can be very painful, as well as cases with infection and swellings, which if untreated can actually be life-threatening. I would now like to speak about supporting the geriatric and special needs scene. As we work towards the goal of healthier SG, we want to ensure oral health is addressed in successful aging and inclusive healthcare. Before I start, I would like to talk about a case of my colleagues. A woman with a severe intellectual disability presented at the geriatric and special care dentistry clinic for treatment. Her challenging behavior meant that treatment under local anesthesia, that means when she's awake, was not viable. However, dental treatment under general anesthesia, which is going to sleep, came with its own set of problems. Risk outweighed the benefits, especially for a single tooth extraction. Furthermore, hospital policy requires legal representation for consent involving mentally incapacitated adults, and obtaining court-appointed deputyship could take months and can be costly. To make matters worse, the woman had previously had a traumatic experience in the hospital environment. Her family therefore chose chairside management after weighing the options. After attempting to prepare her with 3 acclimatization visits, the dentist attempted the extraction with physical restraints. However, due to profound difficulties faced, they just could not do it. The treatment was aborted. This experience highlighted the struggles faced not only by the patient's family in navigating the system, but also the dentist and medical team in treating individuals with complex needs. I would like to touch on a few areas. Number 1, engaging elderly and special care needs patients and their communities. The lack of oral health knowledge and health goals in these groups underscores the need for advocacy and mindset change. Patients and caregivers often struggle to navigate the various services available and may not know who to approach for financial help and other supportive services. To address this, there may be a need for closer cross-collaboration between those involved in their care. Professionals such as doctors, ward nurses, and caregivers need to know basic oral health literacy as well as where to get reliable information for treatment. We can consider looking at nursing clinical practice guidelines to ensure that oral care offered to residents is also up to date and practical. Number 2, reserving capacity for those with complex needs. Dentists are doing their best to help out, but there's a lack of guidance on standards of care. A clinical practice guideline as well as care pathways are needed to help ensure quality and appropriate care is offered. Complex cases with multiple health and behavioral problems can be seen in the hospital settings, and milder cases can be referred to a network of dentists in GP clinics. Complex cases can also be discharged to GPs once they are stabilized. Number 3, the lack of access to dental care in elderly and special needs facilities. Some of our communities and organizations seeing vulnerable persons have taken the lead to develop their own dental capacities. Out of all nursing homes in Singapore, only some have access to on-site dental services through Unity Dental Care buses or mobile teams provided by volunteer groups or institutions. Even fewer homes have a fixed brick-and-mortar clinic run by a volunteer dentist when manpower is available. An example is the Hospice Care Association, or HCA, where a dental kit was built in their newest day hospice, Oasis at Outram. On the special needs front, Minds Developmental and Disabilities Medical Clinic was launched last year and is already working towards providing dental screening and referral services for patients. This has the potential to scale as Minds opens their cross-disciplinary health hubs. However, the lack of coordination between volunteer groups is also a major issue. AIC coordinates care for the caregivers and seniors, but dental services are not included. This results in inefficient allocation of resources such as manpower and unmet needs in homes yet to be served. While we must commend the spirit of volunteerism as well, almost all these services do not have any cost recovery component, making this model unsustainable. The cost of consumables, materials, and manpower needs to be considered if services rendered are intended for the long term. Therefore, to address these issues, I would like to call for more support from MOH and MSF in helping different social service organizations develop their personalized dental capacities. Having on-site dental services has various advantages. For someone with autism spectrum disorder, going to an unfamiliar place for dental care can be a difficult experience. Injections can be scary. Removing a tooth is also scary. Without on-site services, patients have to be ferried to primary care services, which may sometimes require costly private ambulances. Treatment in clinics outside is limited by cross-institutional restrictions on data sharing, higher costs in specialized services, and long waiting times to be treated, plus many more. Therefore, it is beneficial to have dental needs of these seniors and special needs persons to be managed in place. Such clinics will also divert the efforts away from elective treatments such as dental aesthetics and instead focus on primary needs, increasing the efficiency and cost savings. Funding is an important aspect of support as dental services have a high capital cost. Other aspects of support should be flexibility in administration and licensing. For example, we've tried to get a handheld portable dental x-ray as a standard care for extractions done in home-based settings. However, until now, it is still not approved here. Number 4, tapping our dental officers. We, however, still do have a shortage of dentists who volunteer and treat this population. To ingrain the spirit of volunteerism and service, we could have dental officers serve short postings while serving out their bond to treat these elderly and special needs patients. This could also be extended to other vulnerable groups such as the migrant workers. This would hopefully encourage them to do the same when their bond has completed. In conclusion, as we commit to supporting healthcare beyond the COVID-19 pandemic and ensuring consistent and sustainable support, we mustn't forget that dental health is a crucial component of overall healthcare to achieve overall well-being and quality of health. The dental healthcare of vulnerable groups such as the migrant workers and the unique needs of the elderly and special needs populations should not be overlooked. Madam Deputy Speaker, I support the motion.